Let's dive straight into this explainer. We're bypassing the basic physiology and jumping right into mastering the intricate diagnostic mechanisms and management rules of adrenal pathologies. If you're gunning for that top tier, 280 plus board score, you've got to understand this clinical algorithmic pathway with absolute precision. Let's get right to it.
We're thrusting directly into a high-stakes clinical scenario, the adrenal incidentalloma. You know the drill. This is a mass of 1 centimeter or greater that we just happen to find on imaging for completely unrelated reasons. But here is the absolute screening mandate. Every single incidentalloma, regardless of its size or how benign it looks on a scan, strictly requires a functional biochemical workup. Assuming a mass is non-functioning based purely on imaging, well, that's exactly how you fall right into a deadly metabolic trap. We absolutely have to rule out subclinical secretion.
Conceptually mapping out this functional workup is your very first step in flawless navigation. We're looking at the endocrine matrix here, comparing the initial biochemical screens across 3 distinct clinical axes. You've got cortisol excess driven by the zona fasciculata, catecholamine excess pouring out of the medulla, and aldosterone excess originating from the zona glomerulosa. This high-contrast matrix strictly dictates your diagnostic pathway. For every single incidentalloma, you've got to perform targeted screens. Suspecting Cushing's syndrome, the gold standard is a 1 milligram overnight dexamethasone suppression test, or a 24-hour urinary-free cortisol. For a pheochromocytoma, you definitively order 24-hour urinary or plasma fractionated metanephrines. And for Conn syndrome, primary hyperaldosteronism, you check the plasma aldosterone to run-in ratio. But listen closely, this is important. You only check that if the patient is actually hypertensive. A ratio greater than 30 is highly suggestive of primary disease. Now, isolating a critical variance, let's look at the precise mechanism of the dexamethasone suppression test. The low-dose test is just to confirm the actual presence of hypercortisolism, which happens if the morning cortisol fails to suppress below 1.8 micrograms per deciliter. But to actually find the source, that's where we rely on the high-dose dexamethasone test. An ACTH-secreting pituitary adenoma, classic Cushing disease, will typically suppress under a high dose. Conversely, ectopic ACTH production, like what you'd see from a small cell lung carcinoma, ignores negative feedback entirely. It's not going to suppress at all.
All right, let's flip to the opposite end of the spectrum and build the exhaustive 3-step workup for hypocortisolism or adrenal insufficiency. Step 1, an 8 a.m. morning cortisol of less than 3 micrograms per deciliter is highly suggestive. Step 2 is your definitive diagnostic threshold, the cosentropin or synthetic ACTH stimulation test. What you're looking for here is a failure of serum cortisol to rise above 20 micrograms per deciliter after administration. Once you've confirmed that, step 3 is measuring plasma ACTH to localize exactly where the defect is. Notice the exact laboratory deviations based on that ACTH level. Primary adrenal failure, or Addison's disease, uniquely presents with a completely destroyed adrenal cortex. This means low cortisol and an elevated compensatory ACTH, which, by the way, causes that classic skin pigmentation due to MSH co-secretion. Critically, it also means low aldosterone, leading directly to hyperkalemia and hyponatremia. Secondary failure, on the other hand, stems from the pituitary. Your ACTH is low, but the mineralocorticoid axis remains completely spared. Why? Because aldosterone is regulated by the renin-angiotensin system, not ACTH.
Shifting gears to the radiographic signature, when you're evaluating a suprarenal mass, you absolutely must look at its density. Benign adenomas are rich in lipid, so they consistently demonstrate a low Hounsfield unit attenuation of less than 10 on a non-contrast CT. Malignancies or pheochromocytomas completely lack that lipid, showing high attenuation, way above 20 Hounsfield units. Furthermore, benign adenomas wash out more than 60% of contrast at 10 minutes, whereas malignancies invariably retain it. But remember the golden rule. Regardless of the imaging, an immediate functional workup is an absolute requirement before any surgical resection is even considered.
When it comes to catecholamine-secreting tumors, specifically pheochromocytomas, you must commit the rule of tens to memory. It's an absolute classic. This rule dictates that 10% are extraadrenal, which we often call paragangliomas, 10% are bilateral, 10% are malignant, 10% are familial, and 10% occur in children. Recognizing these discrete markers is totally essential for identifying those tricky syndromic presentations like MEN2, neurofibromatosis, or von Hippel-Lindau.
Now let's talk about the operative trigger. Surgery is unequivocally indicated for any hormonally active mass, or really any mass greater than 4 centimeters, regardless of its metabolic activity. That's simply due to the high risk of adrenocortical carcinoma. In active masses under 4 centimeters with benign imaging, we manage those conservatively with serial repeat imaging in 6 to 12 months. Think of the clinical variance this way. A 2 centimeter active mass gets surgery. A 5 centimeter inactive mass gets surgery, but a 2 centimeter inactive mass gets observed. However, executing the removal of a pheochromocytoma without triggering an intraoperative hypertensive crisis requires absolute adherence to a very specific pharmacologic sequence.
So the crucial point here is this absolute management rule. You must utilize alpha-adrenergic blockade first. Phenoxybenzamine has to establish alpha blockade to control blood pressure well before any beta blocker is introduced for tachycardia. Never, ever give a beta blocker first. Doing so blocks the vasodilatory beta-2 receptors, which leads to fatal, unopposed alpha-adrenergic stimulation and a massive, life-threatening hypertensive crisis. It's a mistake you simply can't afford to make. We're going to wrap things up with a master case. This integrates an incidental finding with a masked metabolic trop to test your rigorous adherence to the diagnostic pathway under real-world exam conditions. Picture this. Our patient is a 50-year-old male getting a CT scan just for some kidney stones. But the scan incidentally reveals a 2.5 centimeter left adrenal mass with an attenuation of 5 Hounsfield units. He's completely asymptomatic, perfectly normotensive. What is the imperative next step in his management? Let's execute an exhaustive choice-by-choice explanation. Option A heavily tempts you with reassurance and a repeat CT in 12 months. It plays on those benign imaging features, the small size and low Hounsfield units. But selecting reassurance without biochemical testing is a lethal error. It completely misses the absolute screening mandate. Option B, upfront surgery, is dead wrong. The mass is under 4 centimeters and we don't even know its functional status yet. Option D is incorrect because the patient is normotensive, meaning aldosterone screening isn't indicated at all. Option E, a biopsy, is strictly contraindicated since it could trigger a lethal crisis if this turns out to be a pheochromocytoma. Therefore, the correct choice unequivocally demands option C, the 1 milligram overnight dexamethasone suppression test and metanephrine screening. Remember, size and appearance never, ever bypass the requirement for biochemical screening. If you can flawlessly navigate these intricate mechanisms, avoid those tempting radiographic traps, and execute these strict management sequences without a moment of hesitation, well, are you truly ready to dominate the endocrine block and achieve that perfect score? Keep reviewing these algorithmic pathways, stay clinical out there, and I'll catch you in the next explainer.